And I'll tell you how to do that at the conclusion. So just as an introduction for our two speakers, it's important for you to know that AATOD's been involved in working with justice initiatives for a long time. About 2016, I wrote a fact sheet for the justice community at SAMHSA's behest. I also used a Robert Wood Johnson Foundation grant and a supporting grant from Mallinckrodt several years ago in order to really better get a handle on how we could do this work. I have to say, and I think that our speakers, Kathryn and Jessica, will be able to demonstrate the great progress that has been made over the course of the last several years in reaching into the justice community. We very much support having justice tied in with our treatment resources because it's been too long separate. And so this is part of what is being done. We wanted our colleagues throughout the United States to be better informed about the tremendous resources that Kathryn and Jessica are going to talk about. And clearly there is funding for this that comes through SAMHSA for the Opioid Response Network in the Criminal Justice Initiative or Justice Initiative, and then NIDA for JCOIN, and you'll see that they have a combination of research to treatment and to practice, and that's part of the linkages that Jessica's been working on. So to give you an idea of our speakers, now what we're going to do is please keep in mind that both people will have a chance to do their presentations, and then I'll open for Q&A. And the reason we do that is not to break through the information being presented. So Kathryn, let me tell you a bit about Kathryn. Kathryn Cates-Wessel is the CEO of the American Academy of Addiction Psychiatry, and she has more than 30 years of background and experience in the substance use disorder field in administration, medical education, and policy. She's the Chief Executive Officer of the American Academy of Addiction Psychiatry and Principal Investigator and Project Director for both the Providers Clinical Support Systems, PCSS, and the State Target Response Technical Assistance, Opioid Response Network grants. Prior to work at AAAP, she was the Associate Director of Brown University Center for Alcohol and Addiction Studies for over 19 years and Executive Director of Physicians and Lawyers for the National Drug Policy, which is a think tank of leaders from law and medicine advocating for prevention, treatment, and addicts over incarceration. Prior to Brown University, she was the Associate Director of Residential Treatment Center for Adolescents and for Substance Use Disorders and co-occurring mental disorders. And now finally, what I'm going to do is introduce Jessica Hulsey to you. Again, I'll say some words about Jessica again before she begins, but I want you to understand the combined power of these particular women and these presentations. So Jessica is a CEO, Addiction Policy Forum founder. She began working in prevention at the age of 15 years, which is remarkable in itself, through an anti-drug coalition in Southern California. The next chapters included an appointment by President Bill Clinton to serve on the Drug-Free Communities Commission, serving as a legislative aide to the U.S. House of Representatives, and working to pass and fund the Second Chance Act, which was founded for the Addiction Policy Forum in order to help families and patients struggling with the disease of addiction. Since then, the organization has set out on a large mission, grown a team, a remarkable team, I'd say, of dedicated and talented staff, and raised funds to deploy needed programs and resources. Jessica lives in Maryland and is a mom of 3 extraordinary boys, which she's now vacationing with, so we're happy to have her. And just to be clear, and I've heard Jessica talk about this, addiction is certainly a personal issue for her, and there was addiction in her family that led to homelessness and eventually her mother's incarceration, and she was raised by her grandparents. So I'll just say to you that both of these women are quite remarkable. They are national leaders. They're respected. I certainly respect them. I respect their work, and I'm delighted that they're able both to join us today. From my point, you're in for a treat in understanding the vast resources that these two people are creating through their networks. So first, let's turn to Kathryn, and then when Kathryn concludes, Jessica. So I know you're going to enjoy it, so do pay attention, and then you'll hear from me next once Kathryn's completed, and I'll reintroduce part of Jessica's biography. So Kathryn, it's yours.
Thank you, Mark. I really appreciate it. Jessica, I feel honored to be beside you on a panel, and I look forward to continued collaborations with both of you. Thank you all for having me. As Mark said, I'm presenting today on the Opioid Response Network because we have an initiative about focusing on cultivating law and medicine partnerships. Next slide, please. The overall mission of the Opioid Response Network is it's funded by SAMHSA, and it's really to support states and local organizations and individuals to provide evidence-based practices at no cost. And if I forget to mention that, it's free, everything that we provide. And it's really meant to be driven by the local community. And a major part of what I'm interested in, as Mark said, I've been in this field for a really long time. I know how hard it is to come by funding and resources. We really want to build on existing efforts, enhance, refine, fill gaps. We're not here to recreate the wheel or to duplicate or compete. It really is, how can we meet needs that aren't being met? And so I'm a big proponent of coalitions. How can we bring our resources to the table, working with others and what they do best to help support and provide the best care possible? So again, we really want to focus on training at the local level. And another thing that's unique about the Opioid Response Network is we cover prevention, treatment, recovery across the continuum to address local needs. Next slide, please. So who can submit a request for TA? Everyone, anyone and everyone, from individuals to organizations, cities, state officials, anybody that wants help, the justice system, law enforcement. And our goal is really to provide relevant, culturally responsive training and education that we vetted by consultants that we hire and that we pay for to come and provide the training and education that you need. Next slide. So I wanted to share a brief video. It's really quick. It's about 2.5 minutes or almost 2 minutes, just to give you an overview about who we are and what we do. And hopefully this will give you a better overview of what we're about.
Communities across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network, funded by the Substance Abuse and Mental Health Services Administration.
Since I started Noom, I've lost 70 pounds.
I've lost 97 pounds.
And that's why I don't do the slide presentation. So ORN, so who is our team? The American Academy of Addiction Psychiatry, which is the organization I represent, we are the primary awardee and the collaborating site. In coordination with the Addiction Technology Transfer Center, ATTC, their coordinating site, and Columbia University. The three organizations were the lead putting together this grant. And then we brought in 40 national professional organizations. These are our partners, and it's a vast array of organizations. As you can see, AATOD is one of our partners, as well as a lot of others, not only in the medical community, but it's multidisciplinary, and it covers the National Center for State Courts, the National Sheriff's Association, the National Council for Juvenile and Family Courts, the National Judicial College. So it also encompasses other law, medicine, justice groups, along with the medical, and again, covering prevention, treatment, recovery, and beyond. And I feel very strongly about this. As I said, having been in the field a long time, we all have to come together, and I call it connecting the dots. What do you have and what do you bring? Because you have your own constituents. They're definitely not going to come to addiction psychiatry because that's stigmatized, and people feel like from the medical community, well, we don't have those patients or we don't want those patients. And so a lot of times people, we all know, either think of the legal aspects of substance use disorder and not so much the medical. So how can we come together on this public health and public safety priority and learn to share resources and education and support each other? Next slide, please. So recently, from the Opioid Response Network, anyone can put in a request for a TA. So you as an individual can put it in, as an association, a state, or a community organization, and ask for training and education. And we have a technology specialist that will come within 24 hours online and set up a time to meet with you to get you the training and education you need at no cost. Our partners also put together a stakeholders committee. And anyone of our partners that you saw on the previous page that's interested in law, medicine, justice, probation, parole, beyond, working collaboratively, have come together and to focus on what can we do as a coalition, as a subset of Opioid Response Network. And we just recently put together this flyer that's going to go out, and it's been signed off by a large group of representatives. Next slide. So here are the groups just in this particular subgroup of the law and medicine piece of organizations that have come together. Some of them are ORN partners, and some of them are just interested groups like the State Justice Institute. They're not a partner, but they're very interested in supporting and being a part of our initiative to get the word out of how we can work together. And so we are just starting this committee as one of our stakeholders group as part of ORN of how can we work collectively to share resources, to learn from each other, to make sure that we can enhance and support even beyond ORN. And that's how we build sustainability beyond the grant. And so it will continue. And I think that's a major benefit of what we've done with this large coalition. Next slide, please. So some of the things that we've done specifically in the justice system is we convened 45 state champion judges that were appointed by their chief judge in Reno, Nevada at the National Judicial College. And what we wanted to do was to have foundational level training on substance use disorder. You know, what is the neurobiology of addiction? How does an agonist drug work? How does an antagonist drug work? What is relapse? What are the primary components of evidence-based practice? How can we provide just general foundational information? We also wanted to have cultivation of law and medicine partnerships. How can we get the judges talking with the medical community, have the medical people talking with the judges? It was really interesting to see over the 3 days, the judges were like, wow, I can never get doctors to talk to me. And the doctors were like, oh, I don't really know how to talk to a judge. So there were a lot of barriers that we had to overcome and how we could support that sharing of information and that support of one another. As a result of that, next slide, we developed a resource guide. And that resource guide has just been made available, and anyone can get copies of it electronically. We have it available, and we can provide you with copies of that. It's very comprehensive, but it's very foundational, and it's the medical perspective of what would be helpful for the justice system. It's not giving models of what you should do in the justice system. It's really just what would be helpful for you to know and resources to go to. It's available at no cost, and it's very comprehensive, covering across the spectrum: prevention, identification, screening, and so forth. And then it gets into how we can build collaborative relationships with law and medicine. That resource guide is also being printed, and we'll have copies. I think we have about 5,000 copies being printed, and they'll be made available. So if you're interested in any of those materials, you can let us know, and we'd be happy to send you an electronic copy, or if you have a conference or meeting you want to have printed copies, as long as we have supplies, we're happy to share them. Next slide. The other thing that we're doing is, of the training that we did in Reno, Nevada over the 3 days, we've developed an online course that builds on those trainings, but also heard from the judges what they felt was helpful and useful. What we wanted to have happen is have those champion judges go back into their state, and then they could develop other supports and activities to support ongoing relationships, partnering with medicine. We don't want the judges to become clinicians, because that's not their forte, but they are conveners. When a judge wants somebody to come to a meeting, people will show up, but they can bring all the partners together. And then how can we identify medical experts that can be there to help them with the medical aspects? So we've had several judges go back into their state and to develop initiatives. One in rural Tennessee has ORN define a implementation scientist that comes in, and he wants to provide for all 3 medications in the local jail. And he has the sheriff on board, he has the funding to support a clinician, but he didn't know how to implement it. So he contacted ORN as a result of the training we did at Reno, and now they work with them in the State Department of Health in this rural sheriff's jail to integrate the use of medications within the jail. So that's just one example of what came out of the training in Reno. And now we want to provide this online course to anyone free of charge, again, to provide more information out into the justice system. Next slide. The next thing we're looking at proposing is to have an online discussion forum. And this would be a closed forum for judges only to start with. We wanted to start with the champion judges that we had in Reno and have them have a place where they can post questions either anonymously or in a closed session with addiction psychiatrists who are also, a lot of our members that are addiction psychiatrists are also in forensics and have experience working in the justice system. They can ask questions. They're not clinical cases, so it wouldn't be that, but it's general questions that would be helpful and what resources they should consider in getting some data and evidence to support their decision-making. Next slide. So just to reiterate, to request support for anyone, and not just judges or probation officers or police or teachers, grandparents we've had. If you're interested in submitting a request, it's really easy. Next slide, please. So I think I went through those, so I apologize. Those are some examples of ORN work, just so you have an idea. But if you're interested in submitting a request, you go to Opioid Response Network.org and you can put in a request. Next slide. So just to give you an idea, thus far we were funded in 2018. We've had over 2 million constituents that have already been impacted by the work. And we've had the state of California had their criminal justice clinical staff. We had over 600 of them trained on motivational interviewing. We've had the city of Fairbanks, Alaska works with us on looking at developing a system of care for substance use disorder. We have a grandmother in Rhode Island that put in a request to build a support system and find resources for other grandparents who have custody of their grandchildren because the parents have been incarcerated because of a substance use disorder. So there's a wide range of the types of requests that we get. We've helped over 3 million people. We have closer to 1,000 consultants across prevention, treatment, and recovery, and about 31,000 people thus far have participated. Next slide. So how can we help you? The best thing to do is go to opioidresponsenetwork.org. A technology specialist for your state will contact you within 1 business day, which is really phenomenal. Who gets responses back within 1 business day? That person is well-versed in your community and knows your state, what's going on, works closely with a single state agency, other people in the state. They will contact you within 1 business day and set up a time to meet to go through your request. There's a simple request form that you submit when you go to the Opioid Response Network requesting training or education. You'll meet with them to walk through what is your target audience? What are your goals? Just to find a little bit more. I think it's similar to I call it like a temporary agency. You want somebody to come in temporarily to fill a need. And so they're the one that makes the match between you and what's the consultant. They have pools of consultants in their community or state that can meet your needs. If for some reason there is no one that meets your specific needs, it's our responsibility to provide a consultant that can come in. Now, virtually, that's throughout COVID, we've been doing virtual. If it were face-to-face, as soon as things start moving back to normal, we would be responsible for paying for that person's travel. If they have to come in from another place, or even if they're local, we pay for their travel and their time. So it really is advantageous for you. It could be a local thing where you wanted somebody to come in and educate your staff. It could be a state regional, it could be a national. But we really have consultants that have gone through an orientation program. We vetted them, and they're required to use standardized materials. We have a repository of materials that have been vetted that we expect them to use to make sure that we have evidence-based materials and resources. Next slide. So I feel very strongly about this. I truly believe it takes all of us. It takes a village. So together we can make a difference. And I think as long as we continue to support one another, bring what we can to the table, if you will. I'm a Southern girl, and everybody brings what they do best to Sunday dinner. So not everyone does all the best dishes. So everybody bring what you can bring to the table. Let's connect our dots and let's support each other, particularly around this public health and public safety priority. So thank you very much.
So, Kathryn, thank you. And to our audience, just to be clear, the reality is that we really have tremendous access to resources, and I just wanted you to be aware of this, and this is really a good example of it. So now I can tell you one thing before I turn to Jess. The Justice Resource Guide that Kathryn was talking about is really quite good, and I've read it, and I think it provides an excellent and comprehensive piece of information because ultimately it really is quite in depth. It goes into a fair amount of nuance. It's not a clinical guide per se, but it really is a great resource. So now, again, just a slightly brief introduction because I've already told you a bit about Jessica. Again, she's the CEO of the Addiction Policy Forum, and she's the founder. And she began working in prevention at 15 years old through an anti-drug coalition. She has been in charge of the JCOIN network, which is going to talk about, which is NIDA funded, just as the work that Kathryn is doing is SAMHSA funded. And so I thought it was a neat idea, frankly, to bring the two entities together, because you're going to get a much better idea of how great these resources are. Again, both of these women do impressive work. So now let's turn to Jessica. Thanks again, Jess, for being with us. And I know that the participants will enjoy your presentation as well.
Thank you so much, Mark. I appreciate you having us here today. I'm going to try to share my screen and go over a little bit of the resources and sort of services available through JCOIN, the Justice Community Opioid Innovation Network. Everyone see my screen? All right. So as Mark mentioned, I run the Addiction Policy Forum, and we are one small part of the larger JCOIN initiative, which is funded by NIH and NIDA, National Institute on Drug Abuse. JCOIN is led by Dr. Tisha Wiley at NIDA, and then the component of JCOIN that Addiction Policy Forum is sort of a subcontractor on is the Coordination and Translation Center, which is led by Dr. Faye Taxman at George Mason University. So we are very proud to have a part of this project, a small part of this project, which is a very large initiative and sort of overarching umbrella called Helping to End Addiction Long-Term, the HEAL initiative. So a little bit about HEAL. Congress set aside $945 million for HEAL, for the HEAL initiative. And JCOIN is a collection of sort of studies, research projects, and resource centers that are focused on the justice system. So we're very grateful that Congress, NIDA, and NIH made sort of the partnerships and resources and the studies necessary for the sort of justice lane, a part of the healing studies and the HEAL initiative overall. It's looking to speed scientific solutions to the opioid epidemic, and it focuses on both better treatment and solutions to opioid use disorder, as well as focusing on pain. Now, a little bit of about JCOIN and its vision and our goals. So put very simply, JCOIN is seeking to improve how we treat substance use disorders or opioid use disorders in criminal justice settings. And that's both inside the walls and outside the walls, looking at the entire continuum. There are five main goals that JCOIN sort of focuses on through sort of this vast system of research grants and projects and studies that are underway, along with resources and materials and sort of new opportunities for practitioners and stakeholders like you all. So priority goal number one, we're working to generate new evidence. There are 13 large research hubs that are underway, sort of focusing on different topic areas, but they're spread throughout the country. Second goal is to become a go-to resource for researchers and practitioners, making sure that we are prioritizing both sides of that fence. We're also working to develop a network of researchers and practitioners so we can enhance collaboration between the two. We're working to build capacity, both in research settings as well as practitioner and stakeholder settings, and then speeding the translation of science to solutions. We have this 17-year gap between sort of new research findings and implementation into clinical practice that we hear about in sort of studies and summaries. And I love how JCOIN was constructed and sort of Tisha Wiley's vision about not only making sure we were investing in needed research on sort of different topics that affect this nexus of substance use disorders and criminal justice involvement, but also making sure that we're working with the folks on the ground to close that gap between new scientific findings and how we see those implemented into practice every single day. So working with you all and making sure that we build resources and that we understand challenges and needs among practitioners as these studies are ongoing means that we can really improve bidirectional communication, real challenges that are on the ground, the research that's ongoing, and making sure that we're communicating and sharing that in both directions between researchers and those that are in practice. So the need for JCOIN, I'm preaching the choir a bit for this audience, I know, but we have a lot of individuals that are under supervision or incarcerated who have a substance use disorder. We also know that less than 5% of jails offer medications for opioid use disorder. And we also know that the risk of overdose is 129 times higher than the general public as you release from an institution when you have a substance use disorder. So how can we prioritize this population and make sure that we have more research, more resources, more sort of engagement to make sure that this is a priority population? Now, I've talked a little bit about JCOIN's sort of 5 priorities. But I want to dig in just very, very briefly onto some of the main components of JCOIN, and then really turn towards turn to the resources that we have available to you all. Again, like Opioid Response Network, for free. These are free resources, and we aim to bring as many practitioners into the fold as we can to make sure that we're setting up that bi-directional communication. So here is a quick overview of this very large sort of mechanism that's in place through JCOIN. Now, sort of the centerpiece of JCOIN are the research hubs. We have 13 clinical studies that are underway, really big research projects throughout the country. But then you have 2 resource centers as well, the CTC, the Coordination and Translation Center that I mentioned, as well as the MARC, the Methodology and Advanced Analytics Resource Center. So really large components and foundational components that help all the researchers and practitioners that we engage with JCOIN. Now, part of the CTC is translating research, capacity building, on-demand technical assistance and training, rapid pilot studies that are available, and some community stakeholder resources and engagement. These resources are free and available to each of you, and I'll go through a quick summary of them. We also have a steering committee and work groups that are part of JCOIN. And then on the practitioner side, we have both a stakeholder board. Kathryn and Mark are part of our stakeholder board, meaning that they help sort of inform all of the dissemination and stakeholder engagement priorities and activities that are part of JCOIN, and help us do a better job of bringing new findings out to the community, but also listening and understanding where the priorities and challenges are from our stakeholder members and all of our partners. We also have a practitioner board with a smaller number of members, but also trying to really engage to sort of line folks that do this work day to day so that we can stay up to speed on items that we should be responding to. Now, in terms of the CTC, we have, like I mentioned, capacity building, rapid pilot projects, translation of research. Some of these pieces are really where Addiction Policy Forum comes in. The work of the CTC is coordinated by George Mason University. APF, we do a lot around stakeholder engagement and translating science. You may have seen some of our cartoons or webinars or courses. Those are really some of the skills. As Kathryn said, these are the dishes that we bring to Sunday dinner. I love that. That metaphor to sort of explain how we can all come together to add our sort of skills and the things that we do best to these larger coalition efforts. So a couple things in terms of resources to flag for each of you. And these are your systems, your organizations, your networks, your associations. However you come to this webinar. The first on capacity building, we have the LEAP program, which is learning experiences to advance practice. We have 2 tracks, both scholar tracks and investigator tracks. And this is a opportunity to bring in individuals who are more junior researchers who want to sort of build their career in sort of the nexus between criminal justice and substance use disorder research. There are a host of resources and offerings from classes to mentoring to being paired with another researcher in this space. And we want to make sure that this free resource, which you apply for, there's several offerings a year for LEAP investigators and scholars to put it in application, but it really can help advance. We want to bring more and more people into the sort of research field here. We want to see sort of diversity of folks that are sort of accessing resources and choosing this field as their area of focus. So if you have individuals in your organization or in your association who would benefit from this to sort of advance their research career and practice, please reach out to us. You can direct questions to Warren Ferguson, who's at University of Mass. Memorial and part of the George Mason CTC program. And you can also find information, I'll have the website up at the end, at JCOIN CTC website, jcoinctc.org. I love the LEAP program. We're just putting out sort of announcements of our latest cohort of both investigators and scholars. But to really invest in those that choose this focus area, I think is really important, and sort of to see the courses and the classes and the online formats that Warren and his colleagues are making available is really amazing. The other piece that we have available through JCOIN, similar to ORN, is on-demand technical assistance, particularly if sites need assistance with their research or evaluation design or implementation. You can request support through TTA at jcoinctc.org or reach out to us. This is available to state and local governments, behavioral health agencies, criminal justice partners. Anyone can request TA from the CTC to, in particular, to work on that research component. We also have, and I know this is where lots of ears can sort of perk up, but there are 3 rounds every year of the JCOIN Rapid Innovation Grants, what we call JRIG, which are small grant programs that really are available to have a smaller rapid response to a pilot research design that you might want to have. If there is an initiative or an innovation that you are running out of your program and you want to see that evaluated, or you have a research project idea, these grants are typically on the smaller end, but they come out several times a year. There is a real interest by NIDA to see more practitioners and more of our stakeholder partners come into the fold to apply for JRIG grants. There are a lot of resources and TA available for folks who are newer to NIDA and NIH type grant applications to make this more doable for you, including webinars and sort of on demand. We can answer questions. We have tips for writing these types of proposals, as well as a sample proposal that you can follow. So please, if you have something that you know the world would benefit from a research project or an evaluation on your initiative, and even if you are interested in seeing something evaluated, but you don't have a research partner, the CTC and JCOIN can also help with that as well, by pairing you or recommending researchers that you can engage with. We're also working on this, we call it sort of the match.com, but not for dating, but for practitioner and researchers to connect and really make connections on projects that can work on together. So if you have something innovative and cool that you're doing and you want to get data and to see that published and really dig in, please reach out and know that JRIG is a resource for you. With 3 rounds a year, it means that there's lots of opportunities to figure out how the process works, as well as getting your application in and finding the right research partner to bring into your program as well. Now, the other piece really is where Addiction Policy Forum, as well as TASK, works on as part of the CTC, is how do we engage stakeholders? We have 13 really big studies that are ongoing as part of JCOIN across the whole country. The big categories of research that are ongoing are, one, comparative studies on medications for opioid use disorder in criminal justice settings. We also have a whole set of studies that are focused on linkage to care, on how we sort of use community health workers or peer navigators or linkage to community services as people transition to the community. And we also have several studies that look at the effect of policy changes that we see statewide, such as, let's say, Massachusetts has the policy change to provide all 3 forms of medications for opioid use disorder in jails and criminal justice settings. What is the effect and the impact of that policy change on sort of practice and outcomes for patients? So those are the 3 really big buckets of these studies that are ongoing. We also have the resource centers. We have rapid grants that are going out. We have sort of modeling and other pieces of really interesting studies that are ongoing. in addition to those 13 large hubs. And as we have new data and new information, the real goal with JCOIN that I find, as I mentioned, so intriguing is to really connect with all of you. So you know what new data and information and findings are sort of coming out of JCOIN, as well as other studies in science and other resources that are coming out of both federal partners, as well as state and local partners and other organizations and associations. And our goal in JCOIN is not just to engage with research and just criminal justice agencies or folks that are in charge of those systems, but all of you. We've identified 26 distinct audiences to set up and engage in meaningful engagement, meaning we want to provide direct resources, information, materials, courses, webinars, be responsive to the needs of these 26 fields that we have identified as being critical to this. Now, this is everything from justice systems, health systems, AATOD members, a really important part of this, of making sure that we have those that are on the ground providing services for those with opioid use disorder that we're listening to and providing resources back to you. So one of the pieces that we at APF work on for all of our members, both the stakeholder board and all these audiences, is to provide online courses or eCourses. These are available for free. We partner with different associations. We're definitely reaching out soon to Mark and Kathryn to see if their members are of interest, but we have several that are underway where we take some of the leading researchers in different sort of fields or on different issues, along with leading practitioners and folks who can speak from sort of the on-the-ground practical experience of some of these challenges. So our first one that just launched is implementing MAT or MOUD in correctional settings with the Correctional Leaders Association. We're working with the National Center for State Courts on a series of webinars and courses, actually everything from utilizing medications for opioid use disorder in court settings to stigma, to the cascade of care framework and how that can be helpful for our judicial leaders, as well as stigma. We are working with the Council of State Governments Justice Center on reentry research applications, and also working with some associations of both reform advocates and individuals with lived experience, such as the formerly incarcerated, to make sure that some of these e-courses and content from our research community and our practitioner community is made available to them as well. If you are interested in a course, either one of the modules we already have developed, or have another idea that's a priority for your agency, for your organization, or for your association, please reach out to us. We are developing these at a rapid pace, but trying to make sure that we are responsive to the needs of all of those 26 unique fields. So that is a very quick overview of some of the resources that we have available. I encourage everyone to visit jcoinctc.org. You can sign up for our newsletter to get updates on what's happening out of JCOIN. You can reach out to me at jhalsey@addictionpolicy.org. If you're interested in TA, if you have folks in your organization that would be interested in being a LEAP scholar or investigator, if you have an idea for a grant through our JRIG program, or if you would like to deploy one of our e-courses or webinars for your organization, please let us know. We're here as a resource to all of you, and it's such a pleasure to coordinate and collaborate with Mark and AATOD and all the AATOD members on all of these resources that we are building as part of JCOIN.
So thank you, Jess. That was excellent. It was comprehensive. And again, to our audience members, this was my intent in bringing both Kathryn and Jessica together. I sit on their various advisory groups, so I have a great idea of what they're doing. And now you do. And that's the whole point of this sharing. Because now that you've got these resources, I'm encouraging you to access them. These two people have spent enormous amount of time and great commitment, because that's who they are as people, to assemble these resources. They're very serious about this stuff, as am I. That's part of the linkage among the three of us, our organizations. And basically, as you're preparing your questions, several things. Kathryn, you should know that we're being hit with lots of people who want access to that resource guide. So they want to know what it is that you have done. How do they get it? And just to be clear, and Jess has presented this sort of comparative studies about how medications are being used to treat the opioid use disorder in justice settings is obviously very important to us as well. So given our work, which crosses many thresholds, being treatment providers, opioid treatment programs, Data 2000 practices, the state opioid treatment authorities, the NASADAD members, dealing with all of our sister brother organizations is obviously important. And one thing I can tell you, and this is very important, that just this past Monday, the DEA finally released the final regulations, which will now allow mobile vans to be operational under the aegis of existing OTP license authority. Now, that took, and I'm sure that Kathryn and Jess can understand this, that took years to develop. I don't want anybody to be under the illusion that these sorts of federal issues just sort of like pop out like toast, and because it's not the case at all. These things are really deliberate. And I can tell you, because I've been very close to it, that working with the DEA for the last several years was remarkable. They're very helpful. They're supportive of our field. So I know that people sometimes see the DEA as sort of enforcement regulators, which of course they are, but they are also policy partners to AATOD, as is SAMHSA and ONDCP, and the entities that have regulatory authority. So those operational vans can get started with applications in July 28th. That's going to be the official start date. I'm working with people like CMS Medicare, Medicaid authorities, SAMHSA, other entities that will have jurisdiction in this area. Department of Agriculture actually has funding to site mobile vans in rural areas, rural defined as 50,000 population or less. SAMHSA knows, and Tom Cudero was asked this by reporters just this past Monday during their press briefing. So they are completely aware that funding is going to be requested by states and providers through SAMHSA. So keep all of that in mind as we deal with these issues. So there's a lot going on, and finally, before we open for questions, I just want to let you know that in my 40-year career, and I suspect that Kathryn and Jess would agree, I have not seen such ripe opportunity in working with justice components as I've witnessed in the last couple of years. These judge champions is a great concept because they learn and then they share what they've learned with other judges. And in my experience, no matter how reasonably articulate I may think I am, or whatever my expertise may lend itself to, judges will listen politely to me or other folks in justice, but they listen much more closely to their judicial colleagues. And that's part of what is natural. So with that, I'm looking to see, Angelina, where are we with questions that might be coming in for both Kathryn and Jess? So while we're waiting for some questions, I guess my question for you guys is really going to be, how is it that you can further develop these opportunities, and what can AATOD do to be supportive of you?
Jessica, you want to go first, or you?
Sure. I think sort of direct feedback from, all AATOD members on sort of needs, both on different courses or content, or, what we're working on in terms of TA, to make sure we're responsive to the needs of your members in your network would be helpful. As we have new research that comes out, making sure that this is, that we sort of shorten that link and can get that out to your entire network in a rapid fashion is also a high priority. And as we have new pieces, for example, this month, JCOIN is putting out some recommendations and sort of a summary paper on using person first language and really sort of addressing how we refer to our patients with substance use disorders. We also have a resource on the imagery that we use and sort of what the effect and impact is of sort of imagery or stigmatizing imagery on patients, and sort of what those effects are, both in terms of self-stigma as well as perpetuating stigma in the community. So as we have new things that are available, making sure we get it into your hands, and as we need to develop new things, figuring that out from you all as quickly as we can so we can be responsive would be I think our top priorities.
For us, I think it's go to Opioid Response Network, put in a TA request. And this is a good way for us to get resources to you and help support and fill gaps that you've identified that you don't have the support for, are the individuals with expertise. So, and keep advocating for more technical assistance, because that'll help keep building the framework and the support system to help each other.
And I want to underscore that, and remember, these are resources that are available to you at no cost. And this is where NIDA and SAMHSA have come in. So to reinforce that it is true that our federal government, through these resources, have been really helpful to us. And this is a benefit to the states, to the providers. These are linkages, ladies and gentlemen, and take advantage of them is my point of view, because these resources are available to you now. And I'm not saying they're going to go away, but I am saying to you, you want to take advantage of it. I mean, the ORN initiative, you submit an application, you tell them the topic you want, they will then arrange for the speakers, consultants. If they have to travel, as Kathryn said, that's the case. If you have other areas of concern, again, you know how to reach out to Jess and her associates. So the point of this webinar is that we are crossing into what I perceive to be a very important inflection point in this system. And when I say inflection point, I mean to suggest to you that it's an opportunity to engage people in the justice system, which has really developed and it's matured. But this is our opportunity to interact with our justice components, because from my point of view, and I'll just underscore this issue, the importance of those mobile vans being developed for implementation goes to the heart of OTPs getting these vans, buying these vans, and then getting them, arranging with Department of Corrections and agreements with sheriff's offices and correctional managers, actually getting those vans onto the compounds of the correctional facilities. And get this, what that actually means is that inmates with opioid use disorder are able to access a van for induction into treatment, and also so that they could return once they have fulfilled the requirements of their sentence. They get discharged and go to a treatment program, whether it's an opiate treatment program or a Data 2000 program on release, with a warm handoff. And what have we learned even recently from our colleagues at Kodak in Rhode Island and in the Department of Corrections in Connecticut? Even though they're completely independent operational experiences, there's been a 55% reduction in post-release recidivism. There's been a 60% reduction in post-release mortality. And as our speakers already pointed out, that the people are most vulnerable when they are released. So inducting the individual inmate onto a medication and then sustaining that medication until release with a warm handoff is an effective policy. So the mobile vans enhance that effort. And the mobile vans will also be used to increase access to care by increasing the footprint of OTPs as the hub sites in the programs that are using them. So that's what, as you can imagine, what I'm doing is constantly urging, and that will increase over the next several weeks, and to be sure that there are not barriers or impediments to doing this, because there's a lot of work on invested into these, getting these mobile vans into use. So with that, Angelina, anything that's coming up at this point?
There's a great question about resources for counselors and caseworkers, and that we might have great education and resources for physicians and different medical providers, but making sure all of our different staff in our systems and programs have education too. We do have some pieces that can be used by both caseworkers, counselors, sort of any staffers that are in a program, whether that's in the behavioral health provider side or on the criminal justice sort of behind the walls side. So we're happy to connect with you, Terry, and let you know what we have available. We have some case management pieces, understanding MOUD, understanding the neurobiology of addiction, and sort of could almost be sort of a free course that includes whatever modules are helpful for your counselors and caseworkers in your system.
We also have educational resources across all. The Addiction Technology Transfer Center is one of our partners, and that's a big part of what they do is working with allied health professionals. We have the National Association of Social Workers. We have SUD 101 for the non-clinician, for lay people. So there's a lot of resources, and our responsibility is not just for the prescriber in the ORN, it's for anyone. So if you need someone to provide training for a specific group that's not prescribers or not the medical provider, then it's our responsibility to meet that need at that level.
Well, I can also tell you, there are a lot of my provider colleagues that are the early champions of the mobile vans. There was Ron Jackson at the Evergreen Treatment Program in Seattle. Certainly Carol Butler, one of our board delegates from Maryland, and also actually for many years, our board secretary, since passed away. But these were prominent proponents, and it's sort of, almost a legacy to such people who were the innovators. And I think that from my perspective, this is really going to be moving forward. And so now there's a question, if people are on opioids, why can't they start people in jail instead of just detoxing them? Well, this is an extremely good question. While I have my own answer, I will ask both Kathryn and Jess to give you their point of view. So the question is, if people are on opioids, why can't they start people in jail, starting them on medication and induction rather than detoxifying them?
So we know that the gold standard for treatment of opioid use disorders is medications for opioid use disorder. We also know that, so not only does it decrease risk of death from overdose, it also reduces, all-cause fatalities. So we're going to stabilize and have better outcomes for our justice-involved individuals when we give them access to MOUD. There are, unfortunately, lots of barriers to implementing in different correctional facilities, whether that's jails or state systems. We have great examples and innovations that we see, but we need to keep pushing the envelope. There can be stigma against some forms of MOUD. There can be resistance on the policy side. So I think that we need to follow the science and keep pushing for more uptake of providing all three forms of MOUD in all justice settings. We're looking at different formulations and how sort of they compare head to head in JCOIN studies, but also trying to fulfill TA requests and be responsive to educate our justice partners just what a game changer it is, that we should not be detoxing individuals with an opioid use disorder, but providing them the best standard of care for their medical illness. And that takes a lot of time and patience and making sure we get that science into all the different hands.
Kathryn?
I mean, I echo what Jessica says. I mean, there's a lot of issues around it, a lot of policies, a lot of philosophical views that people, unless you can change them, that this is the appropriate way, you're not just changing a drug for a drug, because there are people that feel like mandating somebody do AA, that's treatment. And if they don't do well at that, then they fail treatment. And so we have to do a lot of retraining. It's not the justice system only, the medical community and the general public and the individuals. Sometimes individuals have access to it, but they don't want it because there's pressure from their family and others that they just replacing one drug for another. So there's some basic foundational level education that we really have to do across all areas. And then to get the policies, the funding to support it, it saves money and it saves lives. So why aren't we doing it? But now having the data like what Jessica talks about, getting that translated so everyday people can understand it. I'm married to a basic scientist and I read it. I'm like, which ones are verbs and which ones are nouns? I'm not exactly sure what the research is saying, but how we can translate that and make it so people can understand it and apply it. And I think that's the piece. Is the stigma, I think by far is the number one barrier that we all have to deal with. If people can't acknowledge that these people deserve quality, not just access to treatment, but quality, effective, evidence-based treatment, we're not going to make any headway. But now that's why with the judges and now with our coalition, we're bringing in probation and parole defense attorneys and prosecutors. I was like, wow, I've never thought about working with them. It was just not our thing. And now we're seeing they're receptive to it. Once they see the science and the data and they can understand it, they can see, wow, this makes sense. Why aren't we doing this? And understand there's a change in the brain. People don't want to just be high, that they just don't want to be sick. So how can we help people understand what the challenges are and how we can work collaboratively and still keep people safe and make people responsible, but how can we do this in a thoughtful way? And I think that's like what we're all trying to do here, is to educate and get the information out so people can make good decisions.
And I agree with what Jess and Kathryn have said. This is a sort of long haul issue. And I brought this up in recent discussions with SAMHSA and ONDCP officials. No matter what we're doing, and even with these impressive resources and components, there needs to be an active national education about how people get into this area, what happens with people, the stages of using opioids, whether it's taking more pills, whether it's crushing pills or nasal use. And this is important. People just don't understand this. And it's very interesting to me, even some of my neighbors in my community ask me questions about this, depending on what's happening in our municipality. But I have raised this issue that stigma is all encompassing. That's why it's so difficult to get a handle on, because it's amazing. In our field, in our culture, it's like, you'd be surprised. Everybody has an opinion about what they think should be done to treat people. And I keep saying to them, well, there are a number of real big game changers these days, namely fentanyl and carfentanil, to say nothing of the combination of methamphetamine. So we're treating a very interesting population of people, and they're using more potent drugs than they did before. When I first walked across the threshold of a program in 1974, the primary problem was heroin and cocaine. Well, that's not the case now, because the drugs out there are really amped up. And even patients thinking they're getting OxyContin from their dealer, and they go into the treatment program on admission, say, well, I'm using a lot of OxyContin. It's drug tested. It turns out they're using fentanyl, but they don't know it. So again, this is a fairly complex situation. And I hope that ONDCP and SAMHSA will take on this issue of how do we educate the American public on what this is and what medications are, because there's still some spooky mystery about what medications do. So I completely agree. Detoxification does not work in this patient population. It just doesn't. And we've got lots of research that demonstrates that continually. So it's a matter of presenting this in a concise way that will interest the American public and begin to break down stigma. That will take years, but we got to start. There's another question that's come in that a person would like to hear more examples of how these resources have been used to assist moderate-sized MAT treatment facilities to increase utilization of our services and then help retain the patient. So I'll read that again. Person would like to hear more examples of how your resources have been used to assist moderate-sized MAT treatment facilities to increase the utilization of our services and help retain the patients in treatment, I guess with the object of connecting into justice settings.
So I think one of the resources that we're trying to build is how justice systems and justice leaders, whether you're courts, law enforcement, pretrial, community corrections, prison, jail, a sheriff's office, reentry services, how we can make the connections to community-based providers and understand how those linkages. We know that effective treatment of opioid use disorder for justice-involved individuals starts behind the wall, particularly for those incarcerated, and must be continued with a linkage to care upon release. And so some of the pieces that we're building in JCOIN is making those linkages so that, you know, our previous question talking about education and building those foundational pieces so that we have justice partners who are you know, coming together and seeing that, yes, I need to provide MAT or MOUD, I need to make this a priority, I'm a partner in this. And then once we have that aha moment and then provide all the training and the resources and the online course or the, you know, in-person training to their staff and to their leadership in their own agency, helping to make the linkage to you all, right, to the community-based provider, because those are the systems and those linkages that we see have great outcomes and have the ability to continue long-term. And there's so many great examples of that. You mentioned Kodak and how they work with Rhode Island system, but there are others, and not just on the state prison side, but we see linking to both court systems as well as diversion and deflection programs, et cetera. So that's one of the pieces that we do at JCOIN. We have what we call Connect, which is that you know, sort of app we're building to make sure that people can find each other, and that can include practitioners finding each other as well as practitioners and researchers linking up.
Yeah, I agree. I mean, I think what we find is that we stay siloed. I mean, not only within the substance use field, we talk to ourselves a lot, not the general medical community, but even more so when you get law and medicine. I mean, it's like cats and dogs. You should say, well, they're over there, we're over here. You just want to put people in jail, and oh, you just want to coddle them, and you don't want to make them responsible. I think those is so much still exacerbates the stigma. People just don't want to go out of their comfort zone. And the more we can get them talking and sharing, the more we understand we have very common goals. We want healthy people that are, you know, contributing to society, that it's going to benefit us all to get them back healthy, get their families together, not clogging up the justice system and the legal system. It takes a lot of time and money. And, you know, people don't want that. The large majority of people want people to be healthy and to be contributing and to be functioning. So I think that the more we can continue, like Jess says, is to build the linkages, share information, have an understanding of what each other is planning to do. We just had a call recently with the DEA, and we're like, oh my gosh, who would ever think about talking with the DEA? They just want to get everybody in trouble, you know. And so let's talk about, you know, you're following up on rules and laws and you're carrying that out, but you need an understanding of what we're trying to do from a clinical piece. So until we can come to those, you know, those abilities to share and respect and understand, that's where you get consensus and you get change. And I think that's what I've been seeing more in the past few years, where justice and medicine are talking and sharing information and how they can help and have the same goal. And I think the more that we can do that and be respectful of each other and an understanding, the language is just so different too. I mean, the vocabulary and how you refer to things. And I think the more we can break down that and just be really, you know, upfront and honest with each other and collaborate where we do have common ground, I think that's the potential for real change.
I agree. And I'm reminded of talking to some, you know, law enforcement officers many years ago when I was directing a clinic, and he's talking about perps that they were arresting. And I said, just to be clear, your perps are our patients from time to time, but once they're in treatment, they're no longer your perps. They just stay patients. So in this sense, we like to transfer what you perceive to be perps into our patient population so they cannot be your perps any longer. And that turns out to be true. So another question that's come up, which is, this is a question put to me, why isn't methadone maintenance or other medications widely adopted in the federal prison system, where you have other initiatives, but it doesn't seem to be in the federal prison system itself? Any of you have comments on why that is the case?
Well, I'm going to speak for APF and not for JCOIN here for this answer. I think it's interesting. At one point in time in my career, I feel like BOP, sort of the federal prison system, was sort of our, there were our innovators and the leaders in new sort of practice and correctional practice. And I think that's really shifted to seeing a lot more innovation come out of individual state systems. So I think it's a priority, and we're working to have all three forms of MOUD provided in federal correction settings. I think that AOC, that federal probation, does a pretty good job, and they're much more advanced than the sort of facility-based provisions of treatment for OUD that the BOP does. So I do see that I think we've seen some innovation and some great practice come out of sort of our federal probation partners. We have a lot of work still to do on BOP itself. They're working on trying to make sure we have some new leadership there, but there has been a shift over the last 15 years where I think BOP has sort of fallen behind some of our state corrections leaders, and we'll have to keep pushing them. I think, again, as both you and Kathryn have said, a lot of this has to do with stigma, of misunderstanding the importance of providing medications to treat addiction, this moving from one drug to another. I think there's more stigma or more education needed even beyond that to understand sort of the biopsychosocial framework of addiction, to understand that addiction is a chronic health condition, not an acute health condition. All of this sort of misinformation that exists in the world and in the community about addiction needs to be unlearned, and then we need to train and provide updated sort of medical-based information to all of our partners, and then we start to see some changes. So BOP is on our list of improvements, but we're seeing amazing innovations coming out of Rhode Island, Massachusetts, New Jersey, Pennsylvania, and other systems. And even when we don't see a lot of progress, we know that there are leaders and there are partners on the ground in those systems who want to advance practice, but it takes time and patience, and we need to make sure that we provide that foundational information and we help them debunk misinformation, debunk stigma, so that they can build systems that respond to addiction as a health condition.
Yep. Kathryn, any point of view?
No, I agree. I mean, I think the unlearning part, I really love that part, Jessica, because it's true. I mean, for such a long time, I mean, even working with the justice system 15 years ago, I would be doing training with judges and they'd say, okay, I'm okay with pharmacotherapy, but not methadone. And I'm like, well, but that is kind of pharmacotherapy. But it's like the stigma around that approach, and it was not acceptable. So there's only one medication. It's like, you really have to look at each individual is uniquely different, just like you would in any medical setting. Same thing in the justice system. Each person is different. And I think the more you bring the data, and because that's what judges and others look at, is the evidence. What does the evidence show us? The more we can bring the science to the forefront so it's understandable, so they can make changes and decisions based on what the science is giving them. Having this research in the setting of the justice system is really key, because then they can say, wow, this makes sense. It's been shown, we can replicate it here, that I can make a decision based on that, as opposed to what I heard about a particular medication or what it is. I think that's a piece that's really going to be the paradigm shift.
Also, I think that, and the audience should know this too, there is activity in Congress around these issues. Congresswoman Custer introduced recently, and with other members of the House, the elimination of the Medicaid exclusion for inmates. This is an important piece. We're supporting this with our legislative actions in committees. And additionally, Congresswoman Custer is now likely to reintroduce legislation about medication-assisted treatment in correctional settings. So if folks from ONDCP or Justice, Department of Justice, or SAMHSA are listening to this issue of the federal prison system is certainly something that you can address. So now this is a good prelude. This is a question for you, Jess, which is, within the healthcare systems arena for JCOIN, do you partner with Medicaid and private insurance, helping to facilitate the understanding and importance of the warm handoff and the role that they play in helping that warm handoff through care coordination?
We haven't done as much bringing our payer partners into the fold as I would like, but it's on our to-do list. So if you have different leaders or folks in your states or different payers that you would like to help us bring into the fold, that would be wonderful, and we would definitely be open to that. I'm sure Kathryn has lots of resources that payers would also benefit from. One of the things that I am slightly fixated on is to build those resources for debunking that methadone stigma. And we have several versions of it so we can get it right. So when we find a new partner that wants to really take this on and sort of understand the data around how we can improve patient outcomes, what gold standard treatment for opioid use disorder looks like in any setting, but in particular criminal justice settings where you have a higher risk of fatalities, particularly upon release. The more people we bring in, and then the more we can customize and have content ready to go, so we can provide that foundational layer of information to change hearts and minds, and then have new partners that are going to join in with us to try to change fundamentally how we respond to this illness in these settings. That's really what we're trying to build. So if you have folks that you want to bring in and would benefit from some of these resources we're building, reach out and we'll run by you all the different options we have, and they can customize it. We also firmly believe that people learn better when they see a familiar face and someone they trust. So we will pair a bunch of addiction psychiatrists that I'm fond of and researchers and all of these really smart research community medical provider folks. But then it's going to be introed by a few state corrections directors or a few judges or a chief justice or law enforcement leaders or prosecutor leaders. When we combine the power of our associations and our leaders in our practitioner fields with our leaders in research and medical practice, that's where I think we hit that sweet spot of getting people information that they believe, that they want to act on, and they start to make this a priority within their own systems.
Another question that's come up is, I can start answering this, is how would someone get a mobile van to come, for example, to Virginia? Well, just keep in mind that the DEA regulation is clear. Van services must be provided within a state. The vans are not allowed to cross state lines. So it is unique to a state. So and the answer to you is something that I'm going to be sending out to the field, the country, towards the end of this week, which is an OTP needs to begin the application process. Now that starts on July 28th. But for now, my recommendation to you is to work with your state opioid treatment authority, begin the process, let them know as an OTP you have an interest in procuring a van. First, you got to get the application in, then you go through funding. And again, from my point of view, programs can access SAMHSA and DOA funding depending on where you are putting the van itself. So if it's in rural areas, DOA. If it's urban, suburban, SAMHSA. And since the State Alcohol and Drug Abuse Authority gets block grants from SAMHSA, you turn to that state authority, and then that's how you do it. So it's not that you're going to get a van from another state to come into Virginia. This is literally a state homegrown system. But the idea is for you to begin the process so that you can increase the footprint. And I'll make another point, which is we have the ability to site satellite medication units, also working under the operational aegis of an OTP as the hub site. Once again, this satellite unit would be connected into the hub site and actually could work in conjunction with mobile vans. Add to that the expanded use of telehealth. So that's sort of the answer to that question. Now, when you're talking about the issue of, there's another question, which I can answer too, which is, 42 CFR, the section delineating take-home bottles has not changed with the times. And at a high policy level, can this be reviewed and liberalized? Well, since I talk to federal officials all the time, I can tell you that this is being discussed at ONDCP and SAMHSA and other organizations. We have learned through COVID-19 that a more liberal policy about take-home medication was used. And now the question is, in a post-COVID-19 environment, what take-home regulations are changed? So I can assure you this is, in fact, being discussed at fairly senior levels. So now a question that comes to you guys. In my 20 years in the field, it seems that any linkages that have been made between prisons or jails or drug court on the one hand and treatment providers on the other hand have been on a one-on-one basis. Have you had success in developing a council or similar organization to make this more systemic?
I put an answer in the chat, but I think we have seen some really interesting and successful partnerships where it's not just one-offs of one linkage and whatnot, but it's more systematic or a more meaningful long-term partnership where individuals with behavioral health disorders are connected with the local partner. I mentioned one, a prosecutor-led diversion program in Essex, Mass. Has a partnership in place where all individuals who are eligible for services from their behavioral health partner are sort of connected directly, and it's a pretty successful partnership that's been going on for 12 years. I think Kodak and Rhode Island have a great partnership, and there's so many others. I think figuring out what those best practices are and those lessons learned, and also making sure what I've learned as a practitioner, it's so interesting. We do a lot of great stuff, but we also need to make sure we take the time to do the evaluations and the research so that our scientific community is aware of our outcomes. So whether it's a mobile van that's particularly innovative and doing well from AATOD members, Mark, or it's one of these programs with a linkage system, or this amazing, someone just texted that there's a judge in Massachusetts who has a recovery coach as a part of a diversion program instead of just jail time. When we have those innovations, those are perfect JRIG applications to put in this year or next year. And if you don't have a researcher you work with, email me. JCOIN will help you find one. But when we take the time to make sure that we have the evidence and sort of the third-party evaluation, and it gets put into those journal publications and on the radar screens for our NIDA and NIH partners, it means that we have more evidence to present to the constellation of leaders and practitioners that we want to take up these programs and see the benefits and the outcomes and how they can reduce recidivism, improve patient outcomes, reduce costs. There's so many faces to this and facets that we should be investigating. I think it's important and a reminder that we need to make that a priority and see that there's new lanes that are being made available to make that easier for our practitioners and our partners.
And so the last question as we wrap up is going to be, can resources be available for providers to help support people to reintegrate back into the community so that the environmental stresses don't increase the risk of relapse?
Yeah, I mean, that's, like I said, ours on the ORN is prevention, treatment, and recovery and beyond. And I think that's the piece, is connecting with people at the local level to continue to have the support and help that you need and to prevent relapse or to prevent any other problems. I think the other thing I would be remiss, and I totally meant to say something earlier, is we really haven't talked about mental health, psychiatric disorders, and that we can't leave that out of the discussion. I think more times than not, it's either addiction or it's mental health. And I think we really need to keep those together and keep talking about the priority there, because we're missing the core of the issue for the large majority of people. And I think it's really important that we continue to support that, to make sure that we do help people to continue to live healthy lives and be productive. But it's not a quick fix. Jessica referred to this earlier. It takes time, and you're reprogramming people's brains and their lifestyle and where they are and how they get there a lot of times. But everybody's uniquely different, and we need to make sure that we can continue to build these linkages across the spectrum, no matter where you work, where you live, anything that you do, that you have support and resources to keep functioning in a productive and positive way.
So with that, as we roll out, look, I think that this has been a very informative webinar. The key to this are the resources that the participants have now gotten. So a couple of things. First, complete the survey at the end of this. Our offices will notify participants through email when the recording becomes available. Certificates of attendance will be issued on request. And I'm so grateful to both Kathryn and Jessica for their sharing these resources. As you can probably have figured out, we are partners. We care for each other. We support each other's work as well. And I'm grateful to what they're doing to help this field. And this is a long-term process, but you can see and bear witness to where we are at this particular point in time. And for SAMHSA and NIDA, for support that AATOD's gotten through Mallinckrodt on these initiatives, this is a real remarkable time. So I hope you have all found this to be of value. We will certainly keep you informed as these sort of partnerships continue. And as we get more questions or requests for materials after this, I will certainly keep both Jess and Kathryn informed, as our offices will be as well. So I hope for the participants, you got something out of this. I just want to thank my staff member, Angelina Badia, for organizing this. She organizes all of our webinars, and for our associates and their staff, certainly Nick Canning for AAAP. And just, I'm grateful for this ability to get these resources out. I am optimistic, and I've been doing this work for 40 years. I have never seen such a propitious time to get this work done. And yes, it means changing hearts and minds. Yes, it means educating people. Yes, it means working more cooperatively with federal and state authorities, but we are at a good point in time. And thank God we're finally pulling away from COVID-19 as well. So with that, enjoy your afternoon. Thank you for joining us. Thank you again for everything that our speakers are offering. Be well.
Bye.